Okay, guys, so let me know if you can see my screen, please, before we get started.
Yes, we can.
Okay, thank you. So, well, as you might have already seen in your infographics, we had to accomplish determined topics, right? Uh, Especially some of them, well, all of them that were related to some specialties. However, we didn't really have enough time because, it is actually a lot of knowledge and it is quite difficult for anybody to talk about that much information. However, we're going to do it, okay? Yesterday we were talking about, or yes, I think yesterday we were talking about a little bit of gynecology, right? And some contraceptive methods. We're going to finish that, I think, with it would be in some other class. However, today we have to get started with the second part of this module, which would be about investigations. If you already saw your infographics, this is the next topic to talk about. Okay, so all the missing topics from the first part, we're going to get to them, but that would be for some other day, please, because it's a lot, and we're going to finish gynecology and some other missing specialties. Okay, today we're going to get started with the second part, which corresponds to investigations, as you might have already seen in your infographics. Okay, so let's go on. So here we have a table of contents. Today, we're just going to talk about laboratory tests, okay? Because as you already know, endoscopy, MRI and ultrasound, X-ray and CT and ECG is a whole new world, each one of them, right? There's a lot of information about each one of these complementary studies, right? So today we are going to focus on laboratory tests. Today we're going to be talking about complete blood count, or CBC, okay? Blood chemistry tests, microbiological tests, and some other tests that you are going to participate. And that would be it for today, okay? Because there's a lot of information. So this would be for this and part of the next weekend, okay? Of the next week, I'm sorry. So let's get started. So first of all, as you can read on your screen, these tests or complementary studies should never replace our clinical reasoning, and they only support our diagnosis, right? We only we always have to mm, trust our guts, right? You know what I mean, right? When you have a patient and you have the physical examination, you ask the correct questions, you can always get to reasonable diagnosis based on your knowledge, right? That is why you are studying medicine, right? Because anybody, and I have had some patients that come to consultation, and it's like they say, hi, I need an ultrasound, I need a CT, I need an MRI, I need this blood test. And some patients do these kind of things, right? It's kind of Well, it's not correct because we do not mess into what we actually don't know about, right? You might be treating a lawyer, and well, personally, I don't know anything about laws. So I just have to consult a lawyer about some problem that I have and that might be related to his or her area, right? So anybody can ask or think that needs some determined complementary study. But the difference between everybody that is not related to the medical field does not have the necessary knowledge that you are getting it, right? You're getting that kind of knowledge, and you can support your diagnosis with these complementary studies. So these methods never have to replace our clinical reasoning. They only support our diagnosis. Okay, if you have a good diagnosis, you can be sure the complementary studies are going to support your diagnosis. I know that, well, as as we have reached this point, I know that you have great knowledge according to the year you're in, right? And at the end of the career, you're going to do great because I can tell by the times that you have answered correctly that you're going to be good doctors and that you will have a good clinical reasoning. That is what we're studying for, right? We're not studying for memorizing some any kind of data. We are studying to reason for clinical reasoning, right? So today we are going to talk about those complementary studies. And this is what we as doctors always are asking for: complete blood count, right? Or CBC. This study, you might have heard of it. In Spanish would be hemograma, right? So this is like the basic laboratory test, right? We always ask our patients this test. There is no exception. I mean, if we have a new patient and maybe he doesn't or she doesn't even need this, but we ask for it, right? We all always do it. So we have to know how to analyze and the correct assessment about the CBC. So what is the CBC about? This is a blood test, of course, and it measures and counts blood cells, right? And it might give you clues for a determined disorder, right? So we have everything that this kind of study does is to give you clues to get a good diagnosis, to support your diagnosis, right? There are some disorders, some diseases that might be completely diagnosed with this complete blood count, and we're going to talk about some of them. Okay, so what is the CBC about? As you can see here, there's a lot of information we can get from a CBC. Here we have uh, an image which is similar to the reports that you are going to get from the laboratory, right? We have a parameter, uh, our patient's values, and some reference ranges, which tell you about each one of these parameters that are what is considered normal, right? We always have ranges. There is no one single number that we are going to talk about. I mean, there's different ranges. In Spanish, rangos, right? In which these parameters are considered normal. So that is the reference range, okay? The range of numbers between uh, these parameters are normal for each one of them. So RBC means red blood count, right? This is, red blood count, hemoglobin, hematocrit, um, and maybe reticulocytes are will have different values according to the altitude above sea level because they're related all to red blood cells, right? So here where I live in La Paz, we have higher values of red blood cells, hemoglobin, hematocrit, and reticulocytes. Some of you live in Cochabamba, right? They have lower because Cochabamba, for those who don't know, um, has certain altitude above sea level. However, it is not as high as La Paz, right? And here we'll also have students from El Salvador, which I consider they're at sea levels. So our ranges can vary from one part to another, right? Especially here in Bolivia, we have to memorize some other numbers, right? Some numbers which are related to our altitude, especially when we're talking about hemoglobin, hematocrit, and red blood cells, right? Because we have more of or higher values according to these parameters. Okay, so red blood cells here in La Paz is between 4.5 million and 5.5 million red blood cells per microliter, right? Hemoglobin also varies, and hematocrit, as you know, is the percentage of red blood cells, and hemoglobin is the concentration of this molecule in our blood, right? MCV, we already talked about it, as well as the MHCH, right? Let me see. Okay. So, does anybody remember what MCV is? Because we already talked about it. Hello, guys.
It
Anybody?
means
Yeah,
uh, corpuscular volume of red blood cells.
great. And what it means um, mean, right? Mean corpuscular volume, right? You're right. And what does this tell us about?
Is the measurement of uh, the red blood cell size.
Yes, it tells us about the size of red blood cells, right? Okay, great. You're Danitza, right?
Yes.
Okay, thank you, Danitza. You got an extra point. You remembered. Okay. Next, we have the MHCH. Does anybody remember what this is? Okay, it tells us about the hemoglobin concentration, but related to the hematocrit. Okay, reticulocytes, you know what they are, right? They are like young red blood cells. WBC means white blood cells, right? And we have some, well, we have different types of white blood cells. We have the bands, segmented, lymphocytes, monocytes, eosinophils, basophils also, which is not written down here, right? And platelets. So we're going to get started with the red blood cells and everything that we can, well, not everything because it would be too much to talk about in one class, but we're getting some general ideas that we already talked about, okay? So disorders related to red blood cells. We already talked about anemia, right? And the opposite to anemia, which is erythrocytosis. Okay, here in La Paz, we have a lot of patients with this diagnosis, which is erythrocytosis. Um, this is actually a disease which is related to high concentrations of hemoglobin and especially high values of hematocrit. We're going to talk about it later, okay? So they're like opposites, right? Anemia and erythrocytosis. This is a piece of an advice that I'm going to give you. Every time you see a patient who you might think has anemia, any kind of anemia, you have to focus on the hemoglobin levels, okay? When you hear anemia related to hemoglobin. And when you hear erythrocytosis related to the hematocrit, not to hemoglobin levels, okay? That is a piece of an advice from my personal experience when I was a resident, okay? So when we're talking about anemia, always think of hemoglobin levels. And we can classify this anemia when we go to, well, when we see the mean corpuscular volume, right? If this patient does have anemia, we have to classify this. We see the MCV, and if the the MCV, which we're talking about volume, right? So the unit would be femtoliters. Okay, so if the MCV is normal, which is between 80 and 100 femtoliters, we call our anemia as normocytic, right? If it is lower than 80 femtoliters, it is microcytic. And if this is the MCV is higher than 100 femtoliters, we have a macrocytic anemia, okay? And we also have to take a look at the concentration of hemoglobin according to, sorry. Okay, we have to get to the concentration of hemoglobin to finish the classification of the anemia. If we have a lower value than, well, if the values are normal between 32 and 36, we have a normal chromic anemia. And if we have a lower value, we have a hypochromic anemia, okay? So if we have a normocytic normochromic anemia, we always have to think about chronic disease anemia, renal disease anemia, and bleeding. They're the main three types of anemia that are related to normocytic and normochromic anemia, okay? If we have a macrocytic anemia and hypochromic anemia, we have to think of two possibilities, mainly iron deficiency anemia and thalassemia, okay? How can we tell which is one. We have to go to the, does anybody remember in Spanish, amplitud de distribución eritrocitaria? It determines the variation in size of all the red blood cells, right? It in English would be RDW, okay? If we have a microcytic hypochromic anemia and our RDW is higher than 15, because the normal ranges are from 11 to 15. So if we have microcytic and hypochromic anemia and our RDW is higher than 15, we already have our diagnosis, which is iron deficiency anemia. And if we have a microcytic hypochromic anemia and our RDW is normal, that means between 11 and 15, we have to consider thalassemia. Okay, if we have macrocytic anemia, which would mean that has an MCV higher than 100, we have a macrocytic anemia, and if we have an MCV higher than 120, we have a megaloblastic anemia, which is caused by vitamin 2 deficiency. And we would have to look for some neurologic symptoms. When we get to talk about erythrocytosis, as I told you, we always have to relate it to the hematocrit, okay? And we can classify our erythrocytosis in mild, moderate, and severe. And the treatment would be based on atorvastatin, okay? This is actually quite used here in La Paz, okay? Atorvastatin, you can relate it to LDH cholesterol, right? It has a different use here in erythrocytosis. It was proven that this medication diminishes the concentration of red blood cells and therefore diminishes the hematocrit. Okay, we also have to give our patients aspirin and a specific diet. And well, I've seen a lot of patients with this condition, and they always, well, here in Bolivia, I don't know if in El Salvador there is something called sultana, right? Which is similar to tea, right? As you know, tea, coffee, and this one, sultana, right, are diuretics. So if well, here, some people, most people think that sultana, okay, is good for this disease. Actually, it's the opposite. And the explanation would be that they well, tea, coffee, and this one, sultana, okay, this beverage, are diuretic. So they decrease the water concentration because they make a person urinate, right? So diminishes the watery concentration in the blood, and the hematocrit increases, right? So we have to avoid well, this patient might have to avoid taking any kind of diuretics. Besides that, we have to recommend our patient to stop eating green vegetables, like well, some of the darkest green vegetables are related to more B vitamin, right? So when our patient eats that kind of vegetables, it will produce more cells, any kind of cells, which of them it would be red blood cells also. So the hematocrit will also increase. So avoiding also red meat, right? And some physical therapy, breathing exercises, okay? Because this disease is actually related to deficient um, ventilation. So we have to get our patient to go to a physical therapist for breathing exercises, okay? Uh, we also have one more related disease. Can anybody tell me what polycythemia vera is? Okay, you're going to find out later, okay? Well, in this kind of patients, we have to look for this sign, which is cyanosis, okay? You can see this patient's fingers are bluish, right? So this is actually what they look like. Actually, they look like this. Okay, we are going on with this disorders related to white blood cells, okay? So the white blood cells normal ranges to memorize easily is from 5,000 to 10,000, right? We consider leukopenia, okay? Uh, a count of less than 5,000 cells and leukocytosis higher than 10,000 cells. What causes, what can cause a leukopenia? There's a lot of causes. Autoimmune conditions, e.g. SLE. Does anybody know what SLE is? Systemic lupus erythematosus. In Spanish, lupus eritematoso sistémico. Okay. Bone marrow damage caused by chemotherapy, ionizing radiation, right? Like when someone has some type of cancer and needs radiotherapy, okay? And some bone marrow disorders, sepsis, vitamin 12 deficiencies. And when we're talking about leukocytosis, uh, some causes of this would be chronic inflammation, leukemia, emotional and physical stress, splenectomy, reaction to some medications such as corticosteroids. So the most common cause of leukocytosis is infection, right? So when you are thinking of an infection in your patient, what do we have to do next? So here we have an example of leukocytosis in which we have a count of over 17,000 cells, right?